the slides on your mobile and you can save it, or you can scan this barcode. So if you scan this barcode, you will get the slides on your mobile, and you can download any one you like to download. So I will leave the barcode for 1 minute. Yes, people are joining. Excellent. Or the other alternative is to search for class point. It's in front of our eyes, and then put this code and put your name, and you will get all things on your mobile. And if you want to save any slide, you can save it straight away to your mobile. Okay, so I will remove it now. Good. So today I am going to talk to you about a very important topic. It is the topic of every day. Every day we see diabetic people because, as you know, we have high incidence and high prevalence of diabetes in the general population all over the world. It is like a pandemic, actually. And one category of diabetic patients are diabetic patients who are complicated with diabetic kidney disease. So it is an important topic and a practical topic which we face every day. It is a long topic, so today I will try to cover idea about the diabetic kidney disease, and I will give touch about the diabetes control in patients with diabetic kidney disease, and we may need another session to continue the other lines of management, because we have new things now which are new to the management and new types of research, especially in the new group, which is the SGLT2 group of medications. Okay, so diabetic kidney disease. So the definition of diabetic nephropathy, okay, so diabetic nephropathy, it is a clinical syndrome characterized by progressive loss of kidney function. So it is progressive gradual decline of kidney function as a direct consequence of diabetes, okay? So the hallmark of diabetic nephropathy is the development of glomerular hyperfiltration. And why hyperfiltration? Because you know the blood sugar, the glucose in blood, will cause some sort of osmotic diuresis and osmosis, which will increase the filtration. And this is the cause, as you know, the patients usually present with polyuria and albuminuria. So this is the hallmark of diabetic nephropathy. Definitive diagnosis of diabetic nephropathy requires a kidney biopsy, but actually this doesn't happen in most of the cases. Okay, why? Because when we correlate certain criteria all together and we exclude certain other criteria, we reach a diagnosis. So you will find that no many of the patients with diabetic kidney disease get renal biopsy. On the contrary of other glomerular diseases at which we like to biopsy people. So looking at the epidemiology of diabetic kidney disease, and actually diabetic kidney disease is a more wider expression than diabetic nephropathy, because diabetic nephropathy uh, should be correlated with proteinuria. You should find proteinuria in cases with diabetic nephropathy. But diabetic kidney disease, sometimes we find diabetic kidney disease and decline due to diabetes without significant proteinuria. So diabetic kidney disease is a more wider expression. So it is the most common primary diagnosis of patients who start dialysis, about 50%. And if you look at chronic kidney disease, you will find that diabetes and hypertension are the most common two causes that cause end-stage renal disease. But the kidney disease and diabetic patients who present with end-stage renal disease can be divided into three groups. So 60% of the patients who reach the point of end-stage renal disease who are diabetic, 60% of them have classic diabetic kidney disease. You find large kidneys due to the hyperfiltration. You find proteinuria more than 1 gram per day. You find diabetic plus minus diabetic retinopathy. Okay, this is classic picture. And usually, diabetic retinopathy is correlated to the nephropathy because they are microvascular diseases. So when the diabetes affects the retina of the eye, causing retinopathy, it affects the kidney as well. So when you have retinopathy, most probably what's happening with the kidney is diabetic nephropathy at the same time. So they are 60% of the patients. And 25 to 30%, and this is very important, have another primary kidney disease in addition to diabetic kidney disease. And this is very important. Not every diabetic patient comes to me with proteinuria or nephrotic range of proteinuria is due to diabetic nephropathy. No, sometimes in 25 to 30%, we find the patient has a diabetic kidney disease background in his kidney, but at the same time, there is another diagnosis, as we will see in the next slide. And 10 to 15% have a typical presentation with ischemic nephropathy. Ischemic nephropathy means people with atherosclerotic renovascular disease, okay? And usually it is characterized by low level of proteinuria. And usually in such patients, you find another clues for vasculopathy, like having at the same time ischemic heart disease, peripheral vascular disease, history of cerebrovascular incidents, and so on. People with ischemic nephropathy. If we look at this slide, it's very important because it expresses the possible pathologic diagnoses other than diabetic nephropathy are found in more than half of patients with type 2 diabetes with proteinuria. So this is what I said, that we have about 25 to 30% of patients with diabetic kidney disease, but come with another primary kidney disease. So you'll find about 20% of this cohort presented with focal segmental glomerulosclerosis, 15% minimal change, post-immune vasculitis, mesangioglomerular nephropathy, SLE, systemic lupus, IgA nephropathy, and so on. This opens our eyes towards this point to avoid neglecting people, because sometimes it happens that we realize that this patient is diabetic. We don't biopsy the patient, and we discover later on that no, the patient has another primary disease. This is very important. Cumulative prevalence of proteinuria is 50 to 60% at 25 years after diagnosis of diabetes. So 50 to 60%, 2/3 roughly of patients after 25 years will have proteinuria. And cumulative prevalence of progression to end-stage renal disease, 60% at 5 years after onset of proteinuria. So proteinuria starts, this is very important for diabetes, that proteinuria starts first, and the decline in the eGFR and filtration rate and kidney function happens later on. This means that at a certain time in the life of this diabetic patient, you will find the patient has proteinuria, but with normal kidney function before this decline starts. And actually, while I am saying that, for sure you are remembering some of the patients you see every day. You may find proteinuria with normal kidney function while they are diabetic and they have retinopathy and so on. And the cumulative prevalence of proteinuria and the progression to end-stage renal disease are similar for type 1 and type 2 diabetes. This table actually is very interesting because how can we differentiate between non-diabetic kidney disease and diabetic kidney disease? So you have a patient where, say, with type 2 diabetes coming to you, and you need to have some clues about differentiation between diabetic kidney disease and if the patient has another primary non-diabetic kidney disease. Okay, so first of all, the onset of proteinuria. In case of diabetic kidney disease, is gradual. You'll find the patient a few years ago had microalbuminuria, and the microalbuminuria is progressive, and now he has overt proteinuria, maybe nephrotic range of proteinuria. So it's a gradual process when you look backwards at his proteinuria progress. But in non-diabetic kidney disease, it is rapid. So the patient had no even microalbuminuria in a blood test maybe 3 months ago or 4 months ago, and all of a sudden he comes with nephrotic range proteinuria. No, no, this is not the typical picture of diabetic nephropathy. In this case, yes, there is rapid onset of proteinuria and non-diabetic kidney disease. Also, the progression of chronic kidney disease. Usually in diabetic kidney disease is gradual, so you will follow a gradual course because it is gradual decline bit by bit. But in case of non-diabetic kidney disease, it is rapid. Okay. Duration of diabetes. Usually it is less likely for diabetic nephropathy to happen in a patient with diabetes less than 5 years. Okay. So if the usually it starts to happen between 5 to 10 years after diagnosis, except in certain occasion, if the patient had diabetes previously but not diagnosed for a few years. Okay, so non-diabetic kidney disease, usually you'll find in a patient with diabetes less than 5 years. So if you have a patient with recent diabetes diagnosed last year, for example, and is coming to you with significant proteinuria or decline in the kidney function, so this means that it is not diabetes. There is something else. For diabetic kidney disease, you find usually the duration of diabetes, as I said, more than 5 years at least, or more than 10 years on the most. Urine analysis. Usually in diabetic kidney disease, it's blunt sediment. All what you find is only proteinuria. At the start, microalbuminuria and then overt proteinuria, okay? But in non-diabetic kidney disease, you get active sediments like hematuria, pyuria, red cell casts. Oh, if I have red cell casts, it indicates glomerulonephritis or glomerular disease. So it is not diabetic nephropathy, okay? So presence of active sediments like hematuria, like pyuria, like casts makes the diagnosis of diabetic kidney disease is remote, and I should search for another disease, okay? Retinopathy usually absent in non-diabetic kidney disease and present, as we said previously, in diabetic kidney disease. Good. Of course, you know this figure. So this figure, it is the classification and the staging of chronic kidney disease. As we know, we have 5 stages of chronic kidney disease from CKD1 to CKD5. And as you know, the KDIGO classification added the proteinuria because it is an important risk factor for both kidney and for cardiovascular mortality as well. So they added the proteinuria to this classification. So we classify patients according to their microalbuminuria in each stage to A1, A2, A3. Sorry. To A1, A2, A3. So A1 patients have normal or mildly increased proteinuria, okay, less than 30 milligram per gram, moderately increased 30 to 300, and severely increased more than 30 milligram per millimole or 300 milligram per gram. And if you look at this figure, you can see we have changes in the color. And you can see as the stage of chronic kidney disease increases, the red color started to appear. This increased the mortality. And the same also if we go transverse with increasing the amount of proteinuria. So the highest risk is here, patient with chronic kidney disease stage 5 and heavy proteinuria. This carries a very high mortality. So if we have a diabetic patient and end-stage renal disease as well, and with heavy albuminuria, this makes the mortality 1.5 to 2-fold greater compared to non-diabetics. So this is very important because it carries cardiovascular and cardiovascular mortality. So this figure is very interesting and important to us, and it shows the principle which we said, that the patient starts to have increased albumin excretion in urine, while the glomerular filtration is still normal. And with lapse of time and increase in the amount of protein in the urine, the GFR starts to decline. So here there is a period in which the patient still has proteinuria, microalbuminuria, and still normal kidney function, and then it declines. We have actually clinical stages for diabetic nephropathy. Okay, so we have 5 stages. The first stage is hyperfiltration. So usually it happens in newly diagnosed patients, that the patient has hyperfiltration due to uncontrolled diabetes. So it can happen in newly diagnosed, or if the patient is uncontrolled. So there is increased blood sugar in blood, the patient has polyuria, there is supernormal filtration rate, and still all things are stable. There is no proteinuria, blood pressure is still normal. And 5 to 15 years, as you can see, microalbuminuria starts to happen, and still the filtration rate is high, normal to normal, but there is microalbuminuria and the blood pressure starts to rise. Later on, this microalbuminuria turns into overt proteinuria. Still, the GFR is normal or start decreasing. It is 10 to 20 years after diagnosis, with increase in the proteinuria, and the blood pressure is elevated. And after this overt proteinuria, progressive nephropathy happens with continuous decline of eGFR and increasing the amount of protein and high blood pressure. This is 15 to 25 years. And then when we reach the point at which the decline in kidney function reaches less than 15 ml per minute, we are in end-stage renal disease and we need renal replacement therapy. So these are the stages of diabetic nephropathy. So this is a figure just to remind you that diabetic kidney disease is more wider expression rather than diabetic nephropathy. And diabetic nephropathy, usually we have microalbuminuria, macroalbuminuria, and GFR decline, as we mentioned. And diabetic kidney disease, GFR decline related to diabetes mellitus, but without albuminuria. What are the risk factors for development of diabetic kidney disease and its progression? Actually, we have non-modifiable and modifiable risk factors. So the non-modifiable risk factors are like genetic susceptibility. You will find some people get diabetic kidney disease more severe than others and even in shorter time than others. So there is genetic susceptibility, or family history of predisposition to abnormal sodium handling and hypertension. Genotypes, angiotensin converting enzyme, ACE, angiotensin 2 type 2 receptor, aldose reductase. So there are some genetic types which are liable. Also regarding ethnicity, Blacks, Hispanics, Pima Indians with type 2 diabetes. Gender, so Caucasian males and African American females. Age, possibly early onset. So early onset diabetes usually has a very big opportunity for diabetic nephropathy because of the long time vintage, the vintage of diabetes, and so consequently duration of diabetes. So they are non-modifiable causes. We have some other modifiable, which are the things we focus on, like hypertension. This is something which we can modify. We can try to control it properly. Early glomerular hyperfiltration, and you may ask, oh, how can we control and modify early glomerular hyperfiltration? It is by adjustment of diabetes, by diabetes control, because the hyperfiltration comes from uncontrolled diabetes and the high blood sugar. So if you can control the blood sugar and maintain it, this is modifiable. And hence comes the third point, prolonged and controlled hyperglycemia, which you can control. Obesity is an important risk factor, as you know, which is modifiable. Tobacco smoking as well is modifiable risk factor. Good. So what are the clinical manifestations? How do you think the patient will present to us? So I think the hallmark usually is albuminuria. Yeah, you have a diabetic patient who has years with diabetes, and he is under treatment. And this patient comes with albuminuria. So there is moderate increase in albuminuria may predict high risk of eventual diabetic kidney disease. As American Diabetes Association recommends screening of microalbuminuria in patients with type 2 diabetes at the time of diagnosis, and then every year after that, but for type 1 after 5 years and then annually. So why is this difference? As we know, that usually we diagnose type 1 diabetes earlier than type 2. People with type 2 may have hyperglycemia and diabetes for a few years and present with the complications. For this reason, we, from the start for type 2, we check annually the proteinuria, but for type 1, we check after 5 years and then annually. Microscopic hematuria, it is important. It may occur in diabetic kidney disease. But if you find significant hematuria and microscopic hematuria and red cell casts, you should rule out other glomerular diseases like IgA nephropathy or focal segmental glomerulosclerosis or things like this. As you know, this is the classification of proteinuria. It is the same as the last table of the chronic kidney disease. So normal, so 24-hour collections, less than 30 milligram per 24 hours is normal, 30 to 300 or more than 300 micro and macro albuminuria. So we know this table very well. So there is a certain term or certain stage called incipient diabetic kidney disease, 5 to 15 years. What does it mean, this incipient? Okay. What happens after we start trying to control diabetes? So the hyperfiltration decreases, okay? And the patient goes into what we call incipient diabetes. So only he has microalbuminuria, okay, overnight albuminuria, and it occurs in 20 to 30% of patients. Less than 50% will progress to overt nephropathy and hypertension. So just to explain it, so you have a patient with uncontrolled diabetes, and then you start management of diabetes, and this hyperfiltration settles, and the patient has diabetes control, but the patient remains in a state of just microalbuminuria with normal kidney function. And later on, this patient can turn into overt nephropathy and hypertension can progress. So structure changes, we find the mesangial expansion and moderate glomerular membrane thickening. Overt diabetic ketoacidosis, it takes also 15 to 25 years. Here, the proteinuria is more than 300 milligram per 24 hours, and it is progressing with progress of the decline in the chronic kidney disease. And at this stage, patients usually present with nephrotic range proteinuria. What are the indications of biopsy in patients with diabetes mellitus? As I said at the start, not many diabetes patients get kidney biopsy for diagnosis, because generally people consider if you have a patient with diabetes for more than 10 years and patient has significant complications like diabetic retinopathy, and the patient has only proteinuria, so most probably it is diabetic kidney disease, okay? But what are the definite indications we should ask for a biopsy? Number one, absence of diabetic retinopathy, particularly in type 1. Here I want to mention that in type 1 diabetes, when you have diabetic nephropathy, you should have diabetic retinopathy in 100% of the patients, okay? Diabetic nephropathy and retinopathy. But in type 2 diabetes, absence of diabetic retinopathy doesn't exclude. So it is not necessary in type 2 that all patients with nephropathy get diabetic retinopathy, but it is absolute principle in case of type 1. So generally, if you have a diabetic patient without diabetic retinopathy, in this case, he is indicated for biopsy to exclude any other disease. Second, as we said, usually the proteinuria is gradual in case of diabetic kidney disease. So if you have acute onset of proteinuria and significant proteinuria, particularly if the patient is less than 5 years from the diagnosis of diabetes, especially type 1, as we said, in this case, yes, this patient is indicated to get a kidney biopsy. Third, which is actually understandable, presence of active urinary sediment like red cell casts or significant hematuria. This actually points at another diagnosis rather than diabetic nephropathy. Number 4, if there is rapid decline in kidney function, especially also if it happened very quickly and in short time, it's worth to have a look because it may be a non-diabetic kidney disease. If you have extrarenal manifestations or positive serology suggestive of other glomerular disease, so like if you find positive ANCA test or anti-GPM, there is low complement, hypocomplementemia, so it may be lupus nephritis, okay? So if you get any other extrarenal manifestations or positive serology, in this case, you should proceed to diabetes mellitus. So in all these scenarios, you should proceed for a biopsy. This is what I said. Patients with type 1 diabetes and diabetic kidney disease almost always have other evidence of diabetic microvascular disease like retinopathy or neuropathy. But the reverse or the converse is not true. Not all patients with diabetic retinopathy have diabetic kidney disease. And diabetic retinopathy is present only in 50 to 65% in type 2 diabetes with diabetic kidney disease. I think this is what we said in the last slide. I will go quickly through the histopathology, okay, of diabetic nephropathy. So you find changes in the glomeruli like glomerular hypertrophy, basement membrane thickening, podocytopenia, mesangial matrix expansion, glomerulosclerosis, nodular or Kimmelstein-Wilson glomerulosclerosis, what we call capsular drop. We find arteriosclerosis and hyalinosis. You know, diabetes is a risk factor for vascular disease. We may find tubulointerstitial cell hypertrophy or tubular basement membrane thickening. So we have a lot of things. So quickly, I will show you some histopathologic pictures like A here, when we find mild and early diffuse diabetic glomerulosclerosis, you can find the sclerotic changes, okay, and hyalinization in the afferent and efferent arterioles, increase in the mesangial matrix, getting some nodular changes and nodules in the kidney. So all these are changes. It is not necessary to go into its details. So let's go into the clinical evaluation of diabetic kidney disease. So in summary, you have a patient with diabetes and proteinuria. Okay, this is the presentation. Okay, so first exclude urinary tract infection. This is important because urinary tract infection or UTI can cause false proteinuria. Why? Because of the cells of the red cell, pus cells and white cells. This can give false positive test for the protein. So if you have a patient with diabetes and proteinuria, first exclude urinary tract infection. Second, look at the urine microscopy. Is there hematuria? Is there microscopic hematuria? Look at the microscopy. Is there red cells or white cell casts? Because if we have white cell casts, it may be pyelonephritis. If we have red cell casts, it may be another glomerulonephritis. This patient will need a biopsy. And quantitate the proteinuria. So you can ask for urine ACR, urine albumin creatinine ratio, or urine PCR, urine protein creatinine ratio. There is an important point I want to mention here, that our urine Diabetic, usually it checks from 300 milligram protein loss. So when you Diabetic the urine in a patient with microalbuminuria who is less than 300 milligram, it will be negative, despite the patient has proteinuria. And this is the reason why in diabetic patients, usually we check urine albumin creatinine ratio, urine ACR, okay, to get the microalbuminuria diagnosis, okay? So here I wanted to mention this point, that if the urine Diabetic is negative for protein, this doesn't mean that this patient has no microalbuminuria or has no proteinuria. No, this patient may have microalbuminuria, because microalbuminuria is not detectable but our urine Diabetic. I think this is very, very important clinical point in our practice. But usually, if you have urine Diabetic detects protein in the urine, okay, this means that usually you will find overt protein, and you can ask even for urine PCR, not the ACR. So you need to know the quantity of proteinuria, because this is important to classify if the patient has microalbuminuria or macroalbuminuria. Does the patient has nephrotic range of proteinuria or not? Also, you need to get a renal ultrasound to see the shape of the kidney. To usually, in case of hyperfiltration, the kidneys are enlarged. Okay, renal ultrasound will make a difference if you are planning for a biopsy for the patient, because if the size of kidneys less than 85 millimeters, 8.5 centimeters, it will be contraindicated to proceed with the biopsy. I mean, if bilaterally they are shrunken kidneys. Serology is important as well if glomerulonephritis is suspected. So we need to look at the ANA, at the ANCA, double-stranded DNA, C3 and C4, especially if you have blood and the protein in the urine, because usually blood and the protein in the urine indicates intrinsic kidney disease. So if you have typical diabetic kidney disease criteria like type 1 diabetes for more than 10 years, retinopathy, previous microalbuminuria and this is gradually progressive, no macroscopic hematuria, no red cell casts, enlarged kidneys, so most probably this patient has diabetic kidney disease, no renal biopsy. But if you have atypical proteinuria, like type 1 diabetes for less than 10 years, patient has no retinopathy, there is nephrotic range of proteinuria without progression through microalbuminuria, so the patient all of a sudden got a nephrotic range of proteinuria. There is macroscopic hematuria, there is red cell casts, we proceed for a renal biopsy. If there is a typical presentation like azotemia and proteinuria less than 1 gram, with papillary necrosis like pyuria, hematuria, and scarring, so or tuberculosis, and there is pyuria and hematuria. So you have clues for other diseases affecting the kidney, which doesn't need a certain biopsy. We don't proceed with renal biopsy. So management of diabetic kidney disease. I think we have about 20 minutes, okay? So I will get some outlines about it, okay? And then I will stop after 10 minutes for any questions. And we can have another session because this is very, very long topic actually. So we have some guidance, some guidelines. So we have managing hyperglycemia in patients with diabetes and diabetic nephropathy, chronic kidney disease. It was published by the APCD and the Renal Association. And we have KDIGO guidelines, which are American guidelines for diabetic kidney disease management. Okay. So what are the main lines of management of diabetic kidney disease? Okay. So we are trying to prevent the diabetic kidney disease. And if it happens, we are trying to improve the general outcome. So initially, for all people with diabetes, we should advise to stop smoking, take regular exercise, avoid weight gain, maintain BMI less than 25. Okay, so generally, control of the cardiovascular risk factors is very, very important in case of diabetic patients. Okay, and then if we have diabetes without microalbuminuria, we still can manage the cardiovascular risk factors. So prescribe aspirin, statin of cholesterol is more than 5.2, maintain hemoglobin A1C less than 70%, 7%, which is 52 millimole per mole, keep blood pressure less than 140 over 80, and check 6 monthly the urine albumin creatinine ratio. Okay, so still at the initial stage, we are controlling diabetes, controlling hyperlipidemia, keeping blood pressure under 140 over 80, and still observing the patient. Then the next stage, if the patient starts to have diabetes with microalbuminuria, in this case, we should start ARB or ACE, angiotensin receptor blockers, or angiotensin converting enzyme inhibitors in all patients, except if the patient is allergic to any of the groups. Here, I wanted to mention a certain point that in diabetic patients, we don't prescribe the ARBs or ACE inhibitors only for blood pressure control, but we may prescribe it in a patient with normal blood pressure to help in managing the proteinuria. Okay, so this is the first point. Second point, we don't combine both together. So, for example, we don't put ramipril with candesartan with losartan. Why? Because the on-target trial showed that combining ACE inhibitors and ARBs increases the risk factor of complications like hypotension and hyperkalemia, and at the same time, there is no added benefit. So we select only one type of tablets, either ACE inhibitor or ARBs. We don't combine. And in this stage, we try. So please look at this. You will find every time the proteinuria increases, our blood pressure target decreases. So without the proteinuria, our target was 140 over 80. And then when we got microalbuminuria, target blood pressure is less than 130 over 80. And in case of overt proteinuria, the blood pressure target is less than 125 over 75. So this is an important point to look at. So here at this stage with microalbuminuria, we will start ARBs or ACE inhibitors in all patients. Blood pressure less than 130 over 80, this is our target. And also will continue 6 monthly urine albumin creatinine ratio. And we titrate the ACE inhibitor and ARBs to maximum dose if tolerable, if the patient can tolerate the ACE inhibitor and ARBs. And as you know, usually when we prescribe ACE inhibitor or ARBs or change the dose, we check the creatinine and the potassium after 2 to 3 weeks. And if creatinine increases more than 30% of the baseline, we stop it. Or if there is hyperkalemia, we stop it. But if we can manage the hyperkalemia, we can continue. If we can add something to help and improve the hyperkalemia. But in case of increase of creatinine more than 30%, we stop it. Then we go to the third stage when patient has diabetes with proteinuria, and the proteinuria now is overt proteinuria. You can check by the urine dipstick. and it may reach up to nephrotic range of proteinuria. In this case, we have the same principle, ARPs or ACE inhibitor in all patients, but blood pressure target here goes down to 125 over 75 millimeter mercury, and ensure that the patient is under renal review. And then we go into the next stage when the patient starts to have declining GFR. So the management strategies, blood pressure less than 130 over 80, and we mentioned about ACE inhibitors or ARPs. But of course, if a patient has problems with both groups, yes, we don't use. Glycosylated hemoglobin less than 7%, which is 52 millimole per mole. Okay. Total cholesterol less than 5 millimole per mole. Smoking cessation, obesity, overall cardiovascular risk management, and diet control. I think I will stop here because we have, or in 5 minutes, I can just mention something, and in the next journal club, sorry, in the next ground round, we can continue. But there is something I wanted to mention about the glycemic control. Okay. So in the glycemic control, we still use the hemoglobin A1C to monitor glycemic control in patients with diabetic kidney disease. But here we have a problem actually with hemoglobin A1C in patients with chronic kidney disease. What is it? Usually, patients with chronic kidney disease, especially advanced cases like chronic kidney disease stage 4 and 5, they are under management of anemia with iron therapy and erythropoietin treatment, and this leads to accelerated erythrocyte turnover. And all of these affects the reliability of the hemoglobin A1C. So iron treatment with erythropoietin and iron replacement therapy leads to decrease in hemoglobin A1C due to the rapid turnover, without effect on diabetes. So this is actually misleading. So you may find the patient has low hemoglobin A1C because the patient also is anemic, has lower hemoglobin, and you are trying to correct the anemia, which affects the rate of turnover. And this may be misleading. So you may get low hemoglobin A1C, okay, without any effect of diabetes due to the overall younger erythrocyte pool. Or on the other hand, if there is decreased erythropoiesis due to iron deficiency or B12, this will lead to increase in circulating aged erythrocytes, which will lead to high hemoglobin A1C, while the patient diabetes is not high actually. And I got a letter from one of the GPs recently saying to me that hemoglobin A1C of the patient is high all the time, but in reality, all the home readings by the self-glucose monitor are low, and the patient goes into hypoglycemia. So what to do? So I asked him to follow the home readings and the self-glucose monitor, because hemoglobin A1C in such cases may be misleading. So in this case, hemoglobin A1C results should be interpreted carefully in conjunction with self-monitoring blood glucose data to achieve glycemic goals at the same time and avoid hypoglycemic risk. Last point I will mention here about the glycemic control, that this is from the ABCD Renal Association guidelines, that our targets for patient with diabetes and chronic kidney disease may be higher than our target for the normal population, especially with advanced chronic kidney disease stages 4 and 5. So our target may be 58 to 68. Of course, if we get next journal club in few months, I will make the other, the next one is for the other half, which about control, diabetes control, about blood pressure control, hyperlipidemia, and how we manage our patients. Thanks for your attention, and I am happy to get any questions.